So the first one is Rachel. Rachel, you're up. So Rachel is coming to us from the University of Pennsylvania, and her oral presentation is a prospective study on adverse childhood experiences and HIV-related risk amongst adolescents in Malawi. Over to you.
Thank you. I'm really happy to be here. I did not count on dancing in front of all of you, but that's a new one for me. But I'm really happy to be here and talk to you about our prospective study on child maltreatment and HIV-related risk among adolescents in Malawi. I know that the term adverse childhood experiences has been thrown around in this workshop a couple times over the last few days. So I want to just take a moment and define that. These are experiences in the first 18 years of life that might be potentially traumatizing to children. So these are things like child abuse, witnessing domestic violence, seeing violence in their community on a day-to-day basis. And there's a really strong literature, mostly from high-income countries, that acknowledges that poor health results from the accumulation of adversities. And so this includes things like cancer later in life, smoking behavior, depression, PTSD, heart disease, suicide attempts, premature mortality, STIs, and even some early evidence that it may be structuring HIV risk. Again, mostly from high-income countries. There are very few studies that have examined the prevalence and implications of childhood adversity in a low-income HIV endemic context. There are reasons why we really need to look at it in this unique setting. The first is that we know from emerging research, really over the last 5 or 6 years, that adversity can be much higher in these contexts. So for example, a study that looked across all of the existing literature, and again, almost all from high-income contexts, found that 13% of adults reported at least one adversity in their life before they were 18. In South Africa, there was a study showing the same outcome, so whether or not they experienced an adversity was 35% of adults. And a study in Kenya said it was 78% of adults. So it's much higher in certain contexts. And the implications of that potentially for HIV transmission is quite large in those contexts. And yet there's almost no research there. The research that does exist is somewhat mixed and contradictory, in part perhaps because there aren't any prospective longitudinal studies. Almost all of these studies ask adults about their childhood experiences. So, 20, 30, 40 years ago, what happened to you? And that recall just isn't that good. There was a study in the US that asked adults about their own experiences of child abuse. And half of those that had a court-documented case of child abuse, so something so bad it rose to the level of the legal system, half of them didn't report that when asked about their childhood. So adult reports aren't always great, and yet that's what we rely on. So it'd be great to have some prospective data from kids, from adolescents who are living this. And almost none of these studies focus on adolescence despite this really critical developmental period, and despite the fact that we know adversity starts to have an impact on their health during adolescence. So our study really asked, does childhood adversity exacerbate HIV risk among adolescents in Malawi? And to answer this, we sampled about 2,000 adolescents in 2017 and 18. They were aged 10 to 17 at the time. And we went back 4 years later and we sampled the same adolescents again. We surveyed them in their local languages, and we asked a series of questions about adversity and about HIV risk behaviors. And we had really good response rates. 99% said, sure, we'll take part in the survey. And then 4 years later, we found over 90% of them. We tracked them all over the districts. Adolescents move around a lot. So I'm really proud of this. We tracked them all over their home districts that they moved. We tracked them to the major cities. Those we didn't find are those who mostly moved to other areas or moved out of the country. So we had really good participation. We interviewed the adolescents, we interviewed their caregivers, and we had biological measures taken by HIV testing counselors. And I know this slide usually goes at the end of a presentation, but I think it's really important to make sure we don't miss it. This was a big team effort. We had hundreds of people involved. This was led by IKA Malawi and by James Mira, and it was particularly challenging in 2021 when we were dealing with a lot of new safety protocols related to COVID. So they did a fantastic job collecting all of this really valuable and high quality data, and I'm really proud of that. Excuse me. So what did we collect? We were looking at adverse childhood experiences. So this means things like physical, emotional, and sexual abuse, it's neglect, it's what's happening in your household. Did you witness domestic violence? Was somebody using drugs or alcohol? Were you orphaned? And it also looks at peer violence and violence in the community. So we looked at 13 kinds of adversity, and that's really important. A lot of studies look at one in isolation, but it's really the accumulation of risk of all of those different traumas that really matters often to these outcomes. And then at follow-up a few years later, we looked at the following outcomes. We looked at behavioral risk, like sexual debut and condom use, and we did a summary score of those. We also looked at intimate partner violence, STI symptoms among women, HSV-2 infection, and HIV. The bad news for our study is that our primary outcome, HIV, was too low to measure. That's great news for everybody else. So we only had 6 seroconverters in 4 years. We'll take that. And then we, of course, looked at this using some advanced statistical methods. So this is just a summary of the exposure of adversity. You can see that there's a range, but on average, kids were experiencing about 5 adversities at baseline, and that went up to 6 by the time they were a little older and later in adolescence. And it follows a fairly clear dose-response relationship. So on the bottom, you see cumulative ACEs, the number of adversities they experienced, and then these bars represent their behavioral risk, and it sort of goes up on a very basic scale. But when we start controlling for things like age and socioeconomic status and different things, some of those associations go away. And in fact, this is the longitudinal findings, which show that there's a slight impact of ACEs, comparing those who have very high ACEs to those who have very low adversity or ACEs. There's a small impact for girls on a couple indicators, as I've highlighted in blue. And then there's a doubling of risk for IPV, intimate partner violence, for both genders. And that's when we're looking at their earlier childhood experiences reported at baseline and what's happening to them later in adolescence. But if we look, there we go. If we look at what's happening, what they report during later adolescence, so what they were reporting in 2021 for their adversity in childhood up to that point, and what their behavior was in 2021 as well, we see a much more consistent association. Almost everything has a significant and fairly strong association with adversity for both genders. So for example, having a lot of adversity, being on that higher end compared to the lower end, results in about a 5-time risk of experiencing intimate partner violence. So what we've learned, I think, from this study is, first of all, child adversity is incredibly common in Malawi, as it is in, I think, a lot of contexts. And our study is really adding to this mounting, sort of emerging evidence that reducing violence and other traumas that kids are facing could really attenuate HIV risk, particularly for girls. It's important to collect this data during adolescence because recall is not great later on. And I think that it's important to note that there are very different conclusions drawn depending on how you implement a research study. So our longitudinal research showed that there wasn't really a consistent association here. It was weak, maybe only there for IPV. But the cross-sectional results showed that recent appraisals of adversity had a really strong influence. And I think that might mean that what kids are experiencing right now, what's foremost in their mind in terms of the traumas that are recent and sticking with them, what they're experiencing for violence at home, at school, in the communities during adolescence may be really important to their behaviors now. But I think we need a little bit more research on that end to confirm that, because that goes against my initial hypothesis, to be honest, which was that this early childhood adversity would be the critical piece driving their behavior later. So we really need to look at what periods, what sensitive periods matter to this behavior. But I think, at the end of the day, we really need to go back to that idea that social and structural change needs to happen. And I know that's been brought up a lot in the prior sessions. And the UN sort of global AIDS strategy does call for addressing the unique social and structural determinants that make adolescents, particularly girls, uniquely vulnerable to HIV. And they highlight things like education and economic stability and employment, which we heard about this morning and which is so vital. But they don't highlight childhood adversities and violence. And I think our research shows that we have to think about a multi-layered approach to addressing violence, not just IPV, not just gender-based violence, but violence at home during childhood, violence at school, violence that they're seeing in the community, and really have a sustained response and a multi-layered response to that experience during adolescence. Thank you.